welcome you here.
Well, thank you. I greatly appreciate the invitation to visit your medical school and present at Grand Rounds, and I'm honored to be here and to have the opportunity to describe our approach to student remediation at the Cleveland Clinic Lerner College of Medicine. I have no disclosures. I really have three goals for this presentation. First, I would like to provide an overview of student remediation to provide a context and a rationale for why we chose our approach. Then I would like to describe our medical school program and our approach to student remediation and follow up with some outcomes that we recently published, and then discuss lessons learned and next steps. But before I proceed, I have a question I want to ask the group, and the answer will involve a percentage. Think for a moment of how many students matriculate to medical schools and actually graduate from LCME accredited programs. Think of the percentage. Volunteers? What's the number?
80%.
80%?
I'll start the auction.
97.
Oh. That was what I was going to say. 97. That's my guess.
So a high figure I'm hearing from the group. And when I recently saw a report from the AAMC, I was surprised to learn that 94% of students graduate within 5 years, and the lower number of 82% within 4 years is really attributed to those who complete dual degree programs and who spend an extra year for research, which is becoming more common now that residency is becoming more competitive. And when you think about the attrition rate of 4 to 6% in medical education and compare it to other fields, we are much lower. In fact, looking at PhD programs, the attrition rate is around 20 to 30% at historical data, and this is the same for those who are in the social sciences and humanities programs and those in the STEM fields of science, technology, engineering, and mathematics. We could say, well, that's PhD programs. If you look at law school, the American Bar Association has an attrition rate historically of about 20% in their programs, and that often this happens within the first year. So it made me wonder, why is medical education's graduation rate substantially higher than that of other professions? And when I have these kind of questions, one of the things that I often do is I go and I search the literature. And when I did, I came across an interesting review. At the Best Evidence in Medical Education website, this is a website that publishes systematic reviews with rigor. I ran across a review that's currently in progress of why faculty are reluctant to fail learners in health professions education. And of the articles they reviewed, there's about 15 right now. I heard a preliminary presentation of the outcomes. The fields of medicine and dentistry and nursing were represented. And there were 5 major themes that they identified. One of the themes is that we do not want to be labeled as bad teachers. If our students do not excel, it's a fault of ours. And also, what occurs is that for schools who place a lot of weight on teaching evaluations, faculty are reluctant to give low assessments to trainees because they don't want to have that label of being a bad teacher that could potentially affect promotion and tenure decisions. We also don't want to be involved with a lawsuit if a student appeals a decision. And for personal reasons, it's very difficult to give bad news to a learner. The emotional reaction, the potential anger a student may express. If this is someone that we've mentored for a period of time, we don't want that relationship to be affected negatively. And we also don't want to ruin someone's dream of being a physician. Often we identify students later, maybe the first clerkship, or further on whenever professional challenges present. And students have already incurred thousands in debt, and certainly we don't want to affect that. And then often for many of our faculty who may be at clinical sites, they may not be aware of remedial programs or processes that exist on the main campus. Other reasons could be we're concerned about keeping the pipeline going. I recently read a report from the AAMC that there's a projected shortage of 95,000 physicians within the next 10 years. And certainly if we have many learners who don't do well in our programs, it can affect the reputation of our program. Students may not want to come to our program. And for anyone who's ever given a satisfactory grade to a student in a clerkship, that's the equivalent of failing. Everyone wants to receive honors, and so there's a culture of inflated grades in medicine as well. Another observation is that often we have limited contact with learners, particularly in clinical sites, and we may not feel qualified to give a low assessment because we haven't had enough contact time, or we may feel that we don't have the abilities to give feedback on complex to measure performance domains. And then telling someone read more may not necessarily help address specific learners' remediation needs. This doesn't mean that we don't have struggling learners in medical education. Medicine is very difficult. It's challenging. You've read numerous reports about the burnout rates that we have among medical students. And we can't necessarily expect our faculty to be able to address this. So one of the things that when you think about the variety of challenges that we have, when you think of medical students, the challenges that they experience could be poor study habits, time management issues, the ability to integrate medical knowledge. When you think of residents, it could be issues with professionalism, issues involving clinical decision making, and so forth. And when you think about the strategies that are needed, a one-size-fits-all approach cannot possibly work. And just like our faculty are reluctant to give low assessments to students, our students are reluctant to admit when they need help. That makes it necessary to have formal remediation. Hauer recently published, or a few years ago, published a literature review where she defined remediation as requiring 3 steps. First, there's a formal identification process. Then there is an attempt at an educational intervention to address that performance gap, and then a formal reassessment to determine the extent to which the learner determined competence. And I looked for a specific paper that gave a definitive answer of what the frequency of remediation is in undergraduate medical education, and I didn't find that paper. But what I did find is a leader in the field in remediation at the University of Colorado who's published that up to 15% of medical students, third-year students, will have difficulty, and that 11 students will have difficulty during their 4th year. In another paper, she reported that 7 to 28% of medical trainees, and that included medical students and residents, would require formal remediation, think about those 3 steps, to achieve competence. I like pretty numbers. And so the number working in my mind is about 15% of our trainees will require formal remediation during medical school. So let's look in our crystal ball and think, how many medical students do you think will require more remediation in the future? Any guesses?
More than 15%.
More than 15%? Others disagree?
I'm not sure why the figure would change over time unless the way we look at them changes.
An interesting
Because
hypothesis.
the input doesn't seem that different. You know, it's not like medical school applications are dropping off or the quality seems to be going down, or if anything, the quality seems to be going up. So unless we look at them differently, I can't imagine they would change.
Well, I think that it certainly is going to stay at the same rate. And as I've given this a little bit of thought, I think it might increase. And I'd like to give 3 reasons why, getting to your point of are we looking at them differently. In 2006, the AAMC charged medical schools to increase their class size by 30%. And the schools stepped up and increased their class sizes. And with the addition of new medical schools, it's targeted that we'll reach that 30% increase in matriculating students by 2019. In addition to allopathic schools reaching that target of increasing their class size by 30%, osteopathic schools, indicated in red, have also increased their size. And if we combine those two, the number of matriculating medical students will increase to 49% by 2019 compared to 2002 figures. And if we use the argument that about 15% of students will require remediation, and we've increased the class sizes by this much, we will probably identify more students who require remediation. The emphasis on outcomes education in recent years, I think, will also provide a framework that will clarify expectations for what we want to see in our graduates. All graduate residency programs now are assessing their trainees based on these 6 competencies. Many medical schools are also adopting these competencies to try to prepare their graduates for residency training. Canada has the CanMeds program, and in other areas, competencies, other parts of the world, competencies have been adopted. And historically, I think we worried about medical knowledge and clinical skills. And now that we have specific standards and milestones to think about what is meant by professionalism and what is meant by interpersonal communication skills, it's likely we'll identify more trainees with areas for improvement. And then finally, the AAMC has launched an initiative to look at specific activities that all graduating students should be able to perform upon entering residency. And these activities incorporate multiple competencies, and there are several pilots going on right now to explore how do we assess these in a way that we can give a trainee a badge that they're able to perform this with limited supervision or without supervision during internship training. So as we cast a wide net in deep waters with more students, it's very likely that we will identify more learners who require remediation during medical school. And given our low attrition rates, I think that we have a societal obligation to identify mechanisms to help struggling learners achieve competence and make sure that we don't overburden our faculty when this occurs. Fortunately, we do have some proven strategies that help with student remediation. One thing is identifying learners early. So incorporating assessment systems in our medical school programs that we can identify learners where there's sufficient time to help them is a good plan. Also, we know that doing more of the same is ineffective. Helping a student pass a test the second time or helping a student pass a clinical skills assessment doesn't get to the root of the issue that they may not have the ability to identify learning needs and use multiple strategies to regulate their learning. Also, tailoring remedial strategies to specific performance domains has been proven effective, and multiple opportunities for deliberate practice and feedback where we can help learners identify how to improve. Adine Calais has argued that we should no longer rely on our faculty to anecdotally, haphazardly help students remediate their deficiencies. What we should do is develop programs of remediation within medical schools and provide adequate resources given the increased number that we anticipate of students who will require remediation. And I think the attention to remediation has given us resources recently where full book-length attention is given to how you can help a learner with clinical reasoning and medical knowledge and professionalism. And I've seen reports of different approaches that schools have used. One model is to have an expert team of physicians and psychologists and educators and therapists diagnose a learner's specific areas for improvement and then have strategies that they develop that the learner adopts to improve. Another is to have courses, faculty-directed courses, tutorial groups to address performance areas in medical knowledge and in clinical skills. And then a third option is to have identified faculty. That could be a clerkship director, it could be a course director, the dean of student affairs, or specific members who will meet with the student, recommend remedial strategies, and have those go in place. And as we looked at these different approaches, we were struck that really the faculty were in the driver's seat. They had the locus of control. They developed the strategies that the learners were intended to adopt. And the role of the learner was missing somehow from this process. And when we think about the literature, and Ryan and Deasy's classic paper, I saw that this has been cited over 16,000 times now, that this paper that told us that motivation is a catalyst for learning. And that if we want to have self-directed learners, we should create learning environments that inspire them to develop intrinsic motivation. And there are really three factors that contribute to intrinsic motivation and the learning environments that we create. One is to provide autonomy, where learners have the ability to choose the areas that they would like to pursue, the strategies that they would like to adopt. Competence, that we provide multiple opportunities for them to practice and develop and demonstrate their skills. And relatedness, that we have interactions with faculty and peers, that they have a community of practice. And when we were thinking about this, we wanted to identify, is there a way that we can create an approach to remediation that gives learners autonomy, where they select the strategies rather than having faculty select those strategies. And to provide a context now, I'd like to describe our program and our specific remediation approach. So in 2002, the Cleveland Clinic Lerner College of Medicine was established as a 5-year undergraduate medical program at Case Western Reserve University. We have a mission to create physician investigators, and given that mission, have a limited class size of 32 students per class. The curriculum is organized around 9 competencies, which I'll describe in a moment, and the specific instructional activities I'll review because it gives you a sense of where students receive their assessment evidence. The basic science curriculum is organized around organ-based courses where students have small seminars and problem-based learning to discuss specific cases. The first year focuses on physiology, the second year on pathophysiology, so what some people would call a double pass system. They also have a longitudinal clinic throughout years 1 and 2. It meets weekly in it meets monthly, twice a month in year 1, weekly in year 2, and it's complemented with clinical skills and communication skills development with standardized patients. In addition, students have 2 research blocks to reflect our research mission, where the first research block in the summer focuses on basic and translational research, and the second on clinical research that's complemented with instruction in bioepidemiology or biostats and epidemiology. And then there is a longitudinal, a vertical thread of research throughout years 1 through 5. Clerkships are taken in year 3 and 4, as with electives, and students have a dedicated year of research that culminates in a graduate level thesis that they have to formally defend. What's probably the most unique about our program is our approach to assessment. We do not have any grades for courses or clerkships, no class ranks, no honor societies. All of our assessments are formative. Most of them are narrative. And the evidence that is collected as a part of this process is in a portfolio that students create. These are the 9 competencies that are used for the basis of promotion decisions and students' competence. Most of these match or align with the ACGME competencies I presented earlier. Research is unique to our mission, and personal development because we think Our learners should figure out the work-life balance sooner rather than later. And reflective practice is also a part of our mission, is that we want to create reflective practitioners, and that's a common denominator for our other competencies. I want to just briefly explain our portfolio system because I think that helps give you a context for how we identify learners for remediation. So all of the assessments that we have go into an electronic database. So in the first year, there's narrative assessments from PBL facilitators and peers and self-assessments about performance, feedback from longitudinal preceptors and research preceptors, their performance on formative OSCEs used to help them identify areas for improvement and strengths, patient logs that are obtained during their longitudinal clinics and clerkships, all of their feedback from research preceptors, and then students have the opportunity to upload unique evidence, PowerPoint presentations that they gave during group learning sessions, research papers that they've published, concepts maps that they created, and so forth. Each student is assigned a physician advisor at matriculation, and the physician advisor serves as a feedback coach. They meet with the student regularly throughout the curriculum, discussing the feedback and offering guidance, and they also help the student create formative portfolios. This is where the student reflects on performance in relation to the 9 competencies, cites specific evidence that they have in their portfolio to demonstrate their performance, and then develop a learning plan with their physician advisor's guidance on areas that they would like to work on as they proceed with the curriculum. At the end of year 1, 2, and 4, students prepare a summative portfolio. For each competency, this involves an essay and then citing specific evidence to demonstrate their performance. And just to make sure that the students aren't gaming the system, the physician advisor reviews this summative portfolio, signs off that it is an authentic representation of the student's work, and then it is submitted to a promotions committee. And this is what's really used for identifying progress within the curriculum and for promotion decisions. So I've highlighted the roles of 2 groups, and I'd like to just go into a little more detail about that. The physician advisor monitors all of the students' performance evidence. They have a dashboard that they can read this tied to the e-portfolio. They also coach students on how to interpret and decode feedback, and they offer anticipatory guidance with the curriculum, what to expect. They provide feedback on the learning plans and the portfolios, and then they also give that verification on the summative portfolio. The promotions committee reviews the summative portfolios, they make performance decisions, and if a student is placed in remediation, formal remediation that involves identification, an educational intervention, and a reassessment, they monitor that process. So I already mentioned that there is a performance decision that occurs with the portfolio at the end of year 1, 2, and 4. In addition, a faculty member, if they have any concerns about a student, can make a formal referral through various mechanisms to the promotions committee. If that occurs, the student has to collect evidence, submit a report to the promotions committee, and they will review that report as well as the summative portfolio to make a decision about the student's competence. And that decision can really have 3 outcomes. One is the student can pass and proceed with the program. Another is the student will receive a pass with concerns, where they're instructed to develop a learning plan with their physician advisor to address areas for improvement. And then there's the formal decision of remediation. So the remediation process works that the student will receive a formal letter from the chair of the promotions committee. And in that letter, the chair will say, I want you to develop a learning plan, obtain your physician advisor's signature on that learning plan, and submit it to the committee for review and approval. If this learning plan is approved, it is on the student's charge. They have the responsibility to implement the strategies and to collect assessment evidence to document their performance. And they submit that to the promotions committee in progress reports based on the timeline that the promotion committee specifies. And once the students have achieved the learning plan goals, they're released from remediation. So you can see the students are really the drivers of their own chariot when it comes to the remediation process. And to get a sense of a remedial plan, it has some required components. First, the student has to identify the competency and then provide a reflection on their performance in relation to that competency. They have to identify what their plan is and have specific outcomes for how they would like to achieve it. Now, this is a brief view of what it is, but these are the 4 components. And really what we're trying to do is model the reflective practice cycle. Our portfolio process with formative portfolios and summative portfolios encourages students to apply this process. We make it even more explicit for students placed in remediation because the literature suggests that learners who are struggling have more difficulty with the reflective process. So, the outcomes. This is what we recently published of comparing the performance of students who were placed in remediation to those who were not. And this involved a retrospective cohort-based design. What I do at the beginning of every year is I meet with students and I tell them that we're interested in producing outcomes of our program, and I ask them to sign a consent form that gives us the opportunity to release routinely collected program evaluation data for research purposes. So that's the consenting process for this design. And in terms of student sources of data, I have some baseline characteristics. Were they placed in remediation, yes or no? Their USMLE performance on Step 1, Step 2 CK, and Step 2 CS. The clinical specialty they matched into, which I've coded as medical, procedural, or surgical. There's an in-house graduation questionnaire that I administer after match announcements that we ask them about their satisfaction with the program, and then the actual remedial plans that they submitted to the promotions committee. I also looked at the promotion committee's letters to determine the referral mechanism. Was this from the summative portfolio or through a faculty referral? What year was a student placed in remediation? And for what competency domains? And then a rather coarse measure is the time in remediation. And this was calculated by looking at the date on the letter a student was released from remediation compared to the date when a student was placed in remediation. So looking at the data, we have had 26 students, there's that 15% number again, who were placed in formal remediation. We observed that fewer women were placed in remediation than men, and that we did not have significant differences in terms of their age or their MCAT score compared to their colleagues who were not placed in remediation. One finding we observed, it wasn't statistically significant, but it was intriguing, that there was a higher proportion of students in remediation that pursued surgical fields. And I'd like to note that we had 177 of 187 students who consented to release their data. In terms of USMLE performance, all students in remediation passed USMLE Step 1 on first attempt. We had 2 students who withdrew from the program before sitting for the Step 2 exams. Of those, 22 out of 24 passed Step 2 CK on first attempt, and 23 passed Step 2 CS on first attempt. When we asked students about their student satisfaction, and I had a 100% response rate for this questionnaire data, 22 of 24 said that they would recommend their program to another student. When I asked the buyer's remorse question, knowing what you know now, would you attend CCLCM? Fewer agreed that they would have attended our medical school program, and that was significantly different from their classmates who were not placed in remediation. So from other outcomes, 13 students were identified through summative portfolios, 13 students were identified through a faculty referral process for formal remediation. And most students, 92%, met the requirements of their learning plans and successfully graduated from our medical school program. So similar to other data that we've seen in terms of attrition rates. Our promotions committee prescribed learning plans for 2 students. And what happened in this case is the students had their plans approved, but for their progress reports, they weren't providing assessment data specifying progress. And so the committee, monitoring this process, requested specific sources of data for students to provide. 3 students were placed in remediation twice, with 1 student repeating for professionalism, and I mentioned already that 2 have withdrawn from the program. One of the things that we observed, and this has been reported elsewhere in the literature, is that we identified students who had areas for improvement in multiple competencies, not just one. When we break down the competencies by year, professionalism was the most frequent reason why students were placed in remediation, with 8 being identified in year 1, 7 in year 2, 4 in year 3, and so forth. The other competencies that came up more frequently were communication and research. And our curriculum had multiple assessments early on that I think led to these decisions. What we were surprised is clinical skills did not present very often at all, or medical knowledge was not nearly the concern that many faculty seemed to have about medical knowledge, and that 75% of our students were really identified quite early. I mentioned already that we had more men than women who were placed in remediation, and the range was from 39 to over 1,000 days. You probably won't see a report published in the literature that has a range this wide. And I think part of it is, as the committee views remediation as students are the drivers of their own chariot, especially for complex performance behaviors like professionalism and communication, where it requires ongoing monitoring and evidence to document change, this can explain the findings. And also, if you look at the first year with our graduation class in 2009, the committee had just formed. And this was based on summative portfolio decisions. And as they had a faculty referral place and had more faith and trust and confidence in the system, they were willing to let students be in remediation longer. Because again, the locus of control was with the student. When we looked at their strategies that students proposed, they didn't strike us as strategies that were different than what a faculty would recommend. Set aside an hour each day to log patient encounters. Reply to emails in a timely manner. There were also strategies that cut across courses and contexts, such as seek feedback from peers and faculty about attendance and attitude. And this would be in PBL context, in clinical settings, and in research environments. For communication, strategies they suggested: consult with a therapist. Revise your writing and correct for grammar. Attend a workshop. Solicit written feedback, again, something that can go across contexts and contexts. One of the things I did is I looked at the promotion letters. And as I looked at the promotion letters to students, I was struck by just how encouraging and positive they were. We reviewed your progress report. We appreciate your professionalism. We encourage you. This is not the kind of failing report card one might have gotten as a child. And we felt so strongly about this is that when we published our paper, we included in the appendix examples of letters of how a student was notified that they were placed in remediation, how a student was notified about progress with a progress report they submitted to the promotions committee, and then another example of how the student was released from remediation. So to conclude, most students were able to develop and implement remediation plans successfully. This model enabled us to identify most students early on who had areas for improvement, and our students refer to this as a TAFE, a targeted area for improvement, which I think really gets to the point that this is an opportunity for learning. And the promotions committee used a very systematic approach to identify students who did not meet expectations in more than one competency. The lessons learned is our model requires viewing remediation as a learning opportunity and not as a punishment. And we have to encourage our faculty that students are not gaming the system, that they're doing the right thing, that they are working on their improvement plans. And for a school who does not have any grades, who doesn't have honors for clerkships, we don't require shelf exams. We're used to reassuring our faculty that students are doing the right thing. As any medical school program can say, they have to have clear policies in place to ensure due process. And I targeted the faculty responsibilities already for our physician advisors and for our promotions committee to make those explicit. One thing that really helped us is our promotions committee, a board of about 24 people, are highly regarded, respected individuals within our institution. These are top leading researchers, department chairs, residency program directors. They are very good at judging physician competence and performance, and they are the future employers of our graduates. And I think because of that, and the respect that the community has for their decisions, the process has credibility. And also our physician advisors play a crucial role, particularly for students who are struggling, recognizing the emotional support and the encouragement that they need. You might be thinking about limitations. We're a small school, we're one program, we're unique. And I would say that I agree with you completely. Our model may not generalize to large schools that have large class sizes or divided campuses, but it could appeal to residency programs. Right now, all graduate residency programs have these clinical competency committees that they have to review student or learner progress in relation to milestones. This might provide a vehicle for learners to develop remedial plans in that model. And residencies don't have grades either. The other thing is our measures of satisfaction don't really capture students' satisfaction with remedial processes. And I think by looking at this, it gave us a sense of where we want to dig a little bit deeper. And our physician advisors they're like athletic coaches. They have a unique approach to help every learner, and it's not a standardized process, although our promotions process is standardized. In terms of future directions, I'd like to explore stakeholders' perspectives in more detail. I did a focus group with our physician advisors prior to coming here. I'd like to talk with students, with our faculty, with the promotions committee, and triangulate those insights to get a sense of how they view this remedial process. Our study, as well as many others I've seen reported in the literature, have identified that more men than women are placed in formal remediation, and that's certainly something to explore in more detail. And there are few longitudinal studies. I could count them on one hand. Ours is one of them. And I have not run across any multi-institutional studies. And I think this is really a ripe area for research. So as I wrap up, I would like to acknowledge my colleague, Dr. Elaine Danifer, who designed our portfolio assessment system, and Dr. John Tetzloff, who has chaired the promotions committee since the onset of our school, the physician advisors, and our promotions committee members who really are critical to having this model work effectively. So I welcome your questions.